Thank you for joining us today. My name is Tabitha Hanlon, and I'm one of the advisors here at the Kentucky Regional Extension Center. Today, we're going to be providing a brief overview of the team bundled care model that some of our Kentucky hospitals have been chosen by CMS to report for. But before we get started, I just want to review a brief disclaimer with you. So the information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. All right, so today our presentation is going to be provided by my fellow advisors here at the REC, Robin Colonel and Jessica Elliott. And again, my name is Tabitha Hanlon. And before we get into our content today, I just wanted to talk about some of the work that we do here at the Regional Extension Center, just in case some of you might not be aware. As a part of the Quality Improvement Program or Value-Based Payment, we do offer services around PCMH and PCSB. The Promoting Interoperability Program for hospitals, we also do HIPAA, SRA, privacy and security, and vulnerability scanning. So we do a wide range of services that we can provide for your organization. So we here at the REC do work with a significant amount of practices in hospitals and healthcare systems, and as well as individual clinicians across the state. We partner not just with our fee-for-service work, but we also partner in quality improvement, EHR implementation, promoting interoperability, and other initiatives. With some of the grant work that we do here at the REC, we've been able to administer over $40 million to our providers and practices across the state. So again, we encourage you to, if you see any grant opportunities or any of our fee-for-service opportunities as well, we'd be more than happy to talk with you about it and get you some more information on the great services that we provide here for our clients. And our agenda today, again, we're going to be covering an overview of the TEAMS model, and we're going to be talking about who is required to participate in that, and just kind of running through some of the ins and outs of the TEAM model program. All right, so with that, I'm going to hand it over to Jessica, and she's going to kind of get into more of the meat of our presentation today.
Hey, this is Robin, and so we're get started with maybe a little history of the bundled care projects that CMS has been using for several years, actually. So we can say that they started with MSDRGs in the late 1990s, and they've tried several times to use bundled care projects to control cost and spending. Bundled payment programs generally provide a single comprehensive payment that covers all of the services involved in a patient's episode of care. When we talk about, the previous impact on hospitals, some of it's been voluntary and then others, have been mandatory. We know MSDRGs are how we're paid on fee for service now. CMS tried to look at how they could make hospitals more accountable for the care they provide, not only within the hospital service itself, but also even post-discharge. And so that's where they have brought into these bundled care projects. When we look at what goes into the payment, CMS generally looks at the services tied to some type of anchor stay, and then possibly maybe even 2 to 3 days leading up to that anchor stay. It just really depended on the project at the time that they were using. And then they'll look at the 30 days post-discharge. Some examples that we have saw as far as bundled care projects include this BCPI initiative. That was started, back in 2016, 2017. I may be off a year or two there with the dates, but we saw that roll out about the time that we saw this quality payment program roll out. BCPI was a voluntary program that involved episodes of care. CMS didn't have the response to that program that they expected. Some large systems dropped out after the first couple of years when deciding that the effort to participate didn't match the incentives to participate. The comprehensive joint repair is another common bundled care project that CMS felt would be successful. As the procedures that were included were so common, they felt like there would be a successful team approach between surgeons, hospitals, and post-acute providers. And this team model is the most recent release of a bundled care project, and that will really be our focus of discussion for today's presentation. So team introduction, team stands for Transforming Episode Accountability Model. It will be a mandatory. It is an episode-based alternative payment model in which selected acute care hospitals will coordinate care for people with traditional Medicare undergoing one of the surgical procedures included in the model, and assume responsibility for the cost and quality of care from surgery through the first 30 days after the Medicare beneficiary leaves the hospital. CMS used core-based statistical areas to identify the selected geographic regions for the model test, and hospitals paid under this inpatient prospective payment system and located in these selected CBSAs are required to participate in team. This is no longer a voluntary project. This is a mandatory project. If you want to go back and look, the list of selected mandatory CBSAs were published in the final rule, the final IPPS rule. And CMS will allow a one-time voluntary opt-in opportunity for hospitals participating until the last day of that last performance period, if they're in the BPCI advanced, or if they're currently in the CJR model. So they could participate in team if they wanted to. Team enrolls traditional fee-for-service Medicare beneficiaries. So your Medicare Advantage patients are not included in this project. It's only your fee-for-service. Remember, if you've heard us say in other webinars, CMS's goal was to get all of their Medicare beneficiaries enrolled in some type of accountable care organization by 2030, and this is their attempt. So team is going to test an episode-based payment approach in which acute care hospitals participating in this model, they're going to receive a target price to cover all the associated cost of care, including the hospital inpatient, outpatient. We'll talk in another slider here about how that's going to work, but the important part is the calendar year start date is January 1 of 2026. And so we have all of calendar year 2025 to get ready for this program for those that are selected to participate. So episodes and processes that are involved. So these are the 5 surgical cases: spinal fusion, lower extremity joint replacement, surgical hip fracture replacement, coronary artery bypass grafting, and major bowel procedures. A couple of these can include inpatient and outpatient treatment because we know that some procedures are done on an outpatient basis. So these begin, as I mentioned earlier, with a hospital inpatient or outpatient stay, and it will include up to 30 days after the individual is discharged. Participants will continue to bill for services under their fee-for-service rate. The billing part does not change for participants. CMS is going to set target pricing that'll include all Medicare Parts A and B items and services that are applicable to the episode. And then there will also be some risk adjustment based on beneficiary and hospital level factors. That target pricing is what determines if you're paid or receive an incentive versus having to receive some negative adjustments there. This program will also be performance-based. So CMS is going to compare your actual spending versus that target price. And then there's also some quality measures there that you have to hit. And then there'll be benchmark years as well. Quality measures are specific to the episode, same for the benchmark measures. The benchmarking years, I said that incorrectly. It's benchmark years, not benchmark measures, but you do have quality measures. Benchmark years include 3 years of trended data. This will be your baseline. So for program year 1, we're going to use calendar years 22, 23, and 24. And that will be pulled into year 1 for benchmarking, be pulled into year 1. And then under the reconciliation process, there'll be some discount pricing that will impact, or this discount factor will impact the target pricing. And then there are some participation track specifics. There are 3 different tracks for this program. And depending on your hospital designation, whether you're considered like a safety net or, a small acute or whatever, that determines which track you can participate in. And we'll cover that a little bit more, a little bit later. I do want to touch back on that benchmarking process. When CMS looks at those 3 years of data for these particular episodes, they weight the years. And so the first year will have less impact on pricing and spend than your third year in that benchmark year. So of course, they haven't made this simple for us to figure. However, they have told us that they will provide data for hospitals no later than 1 month prior to the start of the program year. So we should get some cost and quality data no later than December 2025. So I think this is where I turn this over to Jessica, and she's going to talk about those tracks that I just mentioned and take us through the next few slides.
Thank you so much, Robin. So yes, to kind of build off of what Robin just talked about with the different tracks and just what is at risk with each track, CMS has created in this team model more of a kind of a glide path, sort of like what we see with Medicare shared savings. So track 1 is one-sided risk. You are in this track for a limited amount of time. Everyone can stay in performance year 1. So with 2026, everyone can join this one-sided model. And it is going to have upside only. There is a 10% stop gain limit, right? So there's only so much that if you go above, if you hit your target price or you hit below your benchmark, meaning you have savings, there is a cap to that. And then, and again, that's both for all team participants as well as safety net hospitals. Things are a little bit different with safety nets, the guardrails for this. You can actually, if you're deemed a safety net hospital, you can actually stay in this track all the way through program year 3 before you have to move into the more downside risk-bearing models. Track 2 is where we first see that two-sided risk. If you are one of those safety net rural Medicare dependent hospitals, a sole community hospital, or essential access community hospital, after year 3, you can progress to track 2, and you can stay in there through the rest of the program. So through 2030. This does bear that upside and downside risk, and that's at 5%. And so that is, again, something to take a look at. Again, it's a gradual increase on assuming risk as a part of this APM model. And then finally is track 3. That's that full-sided risk that is available. So this is going to be available starting year 1. If you have operated in a risk-bearing model before, you are welcome to start out in track 1 to be able to be on the hook for up to 20% downside risk, same thing with 20% upside risk. And again, it's open to all team participants. If you are a safety net hospital, you have the option to progress to track 2 or track 3 beyond year 1. Everybody has the opportunity year 1, though, to be in that one-sided track 1 for that first performance year. This is considered an alternative payment model for MIPS and the quality payment program. We're still going to have a little bit more information on that, but we anticipate track 2 would be considered a MIPS APM. So you would have some QPP reporting requirements as far as the APP pathway. And then track 3 would be considered, and our understanding is it would be considered as an advanced alternative payment model. So you would be MIPS exempt, but again, you would be participating via your advanced APM as a part of this team model. So more information to come on some of that different classification. Now, I wanted to talk a little bit more about that regional benchmarking that Robin brought up earlier. So that target pricing is, as she mentioned, is subject to discount factors. So each of the 5 episodes are going to have a discount factor between 1.5 and 2%. And so that's sort of that threshold either way that accounts for variation. So, depending on that particular measure, you could have a 1.5%. Think about it as like wiggle room, right? It's to account for those extreme episodes that you're kind of out of your control, that they maybe have an extreme event that causes a higher level of spending. You're going to have a buffer on either way before you can start sharing in savings or before you would have to have repayment. So it's kind of on 2% on either side of what your target pricing benchmark is set at. And again, as Robin mentioned, for the program year 2026, you're going to have those 3 benchmark years. And again, everything is risk adjusted. There's also, it's regionally compared. It's going to look at medical and social complexity as far as adjustment factors as well. And again, the kind of starting out, ideally you want to have a slightly higher benchmark. So if you do have more acute patients, more complex patients, more patients that are dual eligible for Medicare and Medicaid, you're going to see that those social risk factors come more into play, and it's going to probably put you in a slightly higher benchmark because of those acuities. So again, if you have a higher benchmark, you have an opportunity to have to be able to lower the costs a little bit more, therefore being able to receive more shared savings. And just something to clarify, what is that regional benchmarking? Who are they benchmarking with? It's not just for those folks in the state of Kentucky. The regional benchmark is actually that Region 6, and it's going to be East, South, Central. And that's going to include Alabama, Kentucky, Mississippi, and Tennessee. So it's not just within our state or our geographic region within the state. It actually is across state. It's going to look at just not those traditional fee-for-service beneficiaries as far as your benchmarking. It actually looks at all Medicare recipients receiving care at any of these facilities. It's going to look at even the performance, the average spend across all of the organizations that are in each of these states, whether you're participating in team or not. So that is definitely something to consider. We have some registration requirements to sign up at the individual organization level. We will have that, as well as a link to CMS's team page, and then also a link to sign up for CMS's listserv so that you can get announcements and developments on team as they arise. And we'll make sure that we send that out, those individual links out whenever this webinar becomes published. Now, Robin mentioned some CBSAs. So these are the regions within the state of Kentucky that have been identified to test this model. All of these practices, all of these healthcare systems and organizations are mandatory required to participate. Now, you might not be measured on all 5 of these episodes, and you might be. It just depends on what your current processes are, the types of patients, and the types of procedures that you provide within each of your hospitals or health systems. So you can see we have some coverage all across the state of Kentucky. So again, we want to make sure that everybody is aware of their responsibilities to participating in team to be able to set themselves up for success with this new model. CMS has not announced any other systems or hospitals within the state to participate in this program, but I would not be surprised if after the first year or so, CMS does expand this out into a larger scope. So definitely important to stay on the radar for how this could potentially change and how this could expand to include more hospitals and systems. And then finally, want to talk to you a little bit about some future rulemaking. So there's still a lot of things hanging out in the ether to really sort of determine. One of the things that CMS still has, they've talked about in the IPPS, but they really haven't finalized a lot of detail, are collaborators, their roles, and then their rules or their guidelines. So collaborators are those folks who are a part of the care team, but maybe aren't a part of your hospital or health system. They could be a primary care clinician a couple counties away. They could be somebody providing SNF resources, but aren't a part of your tax ID, different parts of that care continuum that are a part of those episodes. And so it's an opportunity for you to contract with collaborators, and collaborators can participate in shared savings, and they can also participate in shared risk, right? So you can bring them in to help offset some of that risk that you're taking on in tracks 2 or 3. You can also bring them in as an incentive for shared savings and for them to receive a portion of that. We're still waiting on some more details to be fleshed out that we assume will happen in that next IPPS rule or other rules outside of that program. Another question that we've already gotten from some of our hospitals we've talked to is, how is that attribution going to be based when you have hospital to hospital transfers? Does that patient and their information stay with the initial originating hospital, or does it transfer over to the one that that patient actually discharges from? That is still being determined, and we are waiting on clarification for that. And so we will make sure that we share that information out as soon as that becomes available, because that is a very significant point. Robin, do you want to talk about some of the other future rulemaking ideas that are still kind of up in the air?
Sure. So the collaborators and the rules associated with having collaborators, collaborators are your folks that help you with your post-acute care. This could be your skilled nursing facilities, maybe some other specialist therapy, things like that. CMS has said that you can include them, and there may even be some way to split some of that incentives, but the risk sharing is not defined yet. And so we're still waiting on some of that. And then one of the big decision makers are hospital to hospital transfers. Some of the questions we've heard and read include, who gets charged with the anchor stay, and how does that fall back on the original hospital that the patient presented to? What happens if maybe they've presented to hospital A and they're assigned whatever MSDRG, and then hospital B says, no, it really should be this, and things back and forth like that. So still more to come with that. CMS just released the QPP final rule, and we're still digging through that to see if there's anything under that one. And then of course, next spring is usually when they release the IPPS rule. But we know all things, CMS can show up in any of the proposed and final rules that they release throughout the year. So more to come.
Yes, absolutely. You never know what's going to get dropped into what rule. One other thing I wanted to make sure that we mentioned is about that low volume threshold. And so CMS has not set, so like with our cost measures in the quality payment program, usually you have between 10, 20, or 30 episodes that trigger for that cost measure to be scored. CMS CMS has not indicated if they are going to set a low volume threshold for how many individual episodes will trigger that particular measure, that particular condition to be triggered for scoring. So that is something that we are waiting on to see if they're going to set one and then what that would look like. So there is a possibility that you might be providing some of these services, but maybe not meet the volumes. So again, stay tuned for more information on what that's going to look like. And now I'll transition back over to Tabitha to talk about some of our upcoming education that we have available.
Thanks, Jessica. So coming up here in the next couple of months, we have a mini video that's going to cover attestation prep for the quality payment program in 2024. That's going to be released on November the 15th of 2024, and that's going to be for our clients. And then we're going to cover the 2025 physician fee schedule and QPP final rule. And that's going to be a client first look. So keep posted to our Facebook page, because we do have some public facing webinars as well that people that are not clients can take advantage of. So keep an eye on our Facebook for those things. Right. And so we here at the REC would love to hear from you guys. If you have any questions or anything about the webinar today, or if you're interested in any of the services that we offer, please feel free to contact us. We have our phone here, our email, and our website as well. And also, like I said, follow us on Facebook and things like that to stay up to date on the different webinars and things that we have going on. And we are so happy that you guys joined us today. And we hope the information that we've provided is helpful to you. And we want to thank you guys for joining.